Hi, welcome to the webinar, The Unique Challenges of Breast Cancer in Adolescents and Young Adults. I'm Dale Semler. I'm the Helpline Manager at SHARE for the Breast Cancer and Metastatic Breast Cancer Helplines. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Johnson finishes presenting, we will begin the Q&A discussion. You're welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. When asking questions, remember that Dr. Johnson is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speaker. Dr. Rebecca Johnson is a physician in the Division of Pediatric Hematology Oncology at Marybridge Hospital in Tacoma, Washington. Dr. Johnson founded the Adolescent and Young Adult, or AYA, oncology program at Seattle Children's Hospital and is now building an AYA hospital multi-care health system. Her clinical and research interests include patient engagement, cancer epidemiology, and unmet needs and barriers to care among AYAs. She chairs the Southwest Oncology Group AYA committees, co-chairs the National Clinical Trials Network and AYA Working Group, and serves on the advisory board of the Children's Oncology Group AYA committee. So without further ado, I'm going to turn this over to Dr. Johnson.
Thank you, Victoria, for the nice introduction and for the invitation to speak to you all today. I'm excited to talk to you about the unique challenges of breast cancer in adolescents and young adults. And as you may have noticed from the intro, I'm a pediatric oncologist by training, having done a residency in internal medicine and pediatrics. And so you may wonder, first off, why I'm interested in breast cancer in the young adult population. And the main reason is personal. I was diagnosed with breast cancer at age 27 as a second-year resident, went through surgery and chemo, had a second separate breast cancer diagnosis in my early 40s. And so the psychosocial and medical needs of this population are really important to me. And in my work every day, I am aiming to make life better for young patients who are diagnosed with all types of cancers, breast cancer being a really important one of them. So the National Cancer Institute defines adolescents and young adults, or AYAs, as people diagnosed with cancer between the ages of 15 and 39. And that age group will be the focus of my discussion today. So I'm going to talk about incidence and prognosis of breast cancer in adolescents and young adults, risk factors for breast cancer in this age group and how they differ from patients of other ages, special age-specific issues that affect young women, and clinical management of AYA breast cancer. And then we have developed a checklist. Specifically, a colleague of mine, Julie Graylow, has developed a checklist of things that practitioners should consider when they have a patient in front of them who has a breast cancer diagnosis at a young age. And so I think that's really clinically useful, both for healthcare providers and for patients as they go through and think about the areas that they need to address as they go through therapy. So incidence and prognosis first. When I was diagnosed, it seemed like the breast cancer diagnosis really came out of the blue. My breast oncologist said, hey, look, breast cancer is really rare in young women. It usually happens in older women. And I said, well, how rare is it? And they said, well, no one knows. We don't know, actually. And at that time in the late 90s, no one had ever looked at AYA specifically as a population. And when we started to do that in the early 2000s, It turns out that breast cancer is actually the most common cancer of adolescents and young adults, and far and away the most common cancer of AYA women. It comprises a little more than 5% of all breast cancers. About 1 in 20 breast cancers are diagnosed in women under age 40. And by the time you get to be 40 years of age, 1 in 171 women will have a diagnosis of breast cancer. So really, that's rare compared to the incidence of breast cancer in older women, in which 1 in 8 women gets breast cancer in her lifetime. But as a cancer in young adults, it's quite common. As we all know, cancer is the most common thing that causes death by disease in adolescents and young adults. So if young women get sick, it's often with breast cancer. In the United States, about 13,000 women get breast cancer every year in the AYA age range, and about 1,000 women will die of breast cancer that was diagnosed when they were between the ages of 15 and 39. Now, a note about teenagers: breast cancer really is very rare in teenagers, and so the AYA designation, again, is from the National Cancer Institute, but the vast majority of AYA breast cancers are actually cancers of young adult women age 20 and up. Worldwide, there is little geographic variation in the incidence, and it occurs across the globe in all races and ethnicities. In Europe, it has been reported in the past decade or so that their incidence is rising for breast cancers of all stages in young women, starting at about 1990. And I'm going to show you now some recent data from the United States that unfortunately shows the same thing. So this figure shows the incidence of breast cancer on the y-axis here in women between 15 and 39 years of age. And on the dashed line, the highest one is all breast cancer, which includes carcinoma in situ and also invasive breast cancer. And the lower bar is the incidence per 100,000 women of invasive breast cancer. And you can see that that's going up measurably between the years 2014 and 2017, the last evaluable year here. And then on the right side, it looks by stage. And between 2004 and I guess it's 2018, you can see that the rates of localized, regional, and distant disease have increased, but the highest angle of increase is in distant metastatic disease. And that's a big problem, actually, because, of course, survival for metastatic disease is far worse than with the lower stage disease. And so a rise in distant disease is a clinical issue that really needs looking at, and we really need to find out why it's happening. Now, if you look at the biology of AYA cancer, if you look under the microscope at the tumors and do genetic profiling on them, you'll find that breast cancer in younger and older women is not equivalent. So the aggressive basal subtype of cancer, shown here in red, is the most common by far in young women under the age of 40, shown in the left column, and decreases the older women get, such that it comprises only about 13% of cancers in women 70 years of age or older. The basal subtype, in addition to being the most common in AYAs, is very common in African American women, which is, we think, related to their poor outcome from the disease compared to women of other ethnicities. The luminal subtype, so luminal A and B, is shown here in kind of purple and periwinkle colored bars. And as you can see, that's relatively less common in AYAs than in older women. And this is an estrogen responsive type of tumor that has a better prognosis overall. And so that type is much more common in older women, whereas the aggressive basal type and HER2 type as well tend to be common in younger women. Now, if you look at incidence by stage, young women compared to older women are more likely to be diagnosed with a higher stage and advanced stage cancer when they're diagnosed with breast cancer. So enclosed in the pink box here are women from the age of 15 to 40. And on the y-axis, it shows you the proportion of women that are diagnosed with each stage. So you can see that about 2/3 of all women under the age of 40 with breast cancer are diagnosed with disease that has spread. So stage 2, stage 3, or stage 4, with the earlier stages, stage 2 and 3 being regional spread of the tumor, and stage 4 being distant metastatic spread of the tumor. Whereas if you look at older women, say women about 65 or 70, about 2/3 of them are actually diagnosed with very early stage disease, stage 0 carcinoma in situ, or stage 1 disease. And so young women are getting bad breast cancer, not just because they have aggressive types of tumors with histology showing lots of cell divisions, but also because the tumors have spread more by the time these women are diagnosed. And of course, survival has a big impact on prognosis. So if you're diagnosed at an earlier stage, you're far more likely to survive your cancer than if you're diagnosed at a later stage, particularly stage 4 disease with distant metastatic disease, which is shown here in the red line that points downward. Now, one thing you can see in this figure is that survival from cancer goes significantly down in the elderly. And so that line is sort of decreasing in the very oldest age groups, which is true for many types of cancer. So looking at cancer survival in the AYA age group, you can see that survival is not quite as bad as it is in the elderly, but again, very inferior compared to women who are in their 50s and 60s. And again, looking at stage 1, 2, and 3 cancer, women in their 50s and 60s are actually doing significantly better. As you can see, the survival is sort of upsloping the closer you get to age 40, with the youngest women actually doing the worst with early stage disease. And so the fact that the survival differences are not solely due to adverse biological features. So if you age match people and you say, okay, well, this woman had, this stage of disease and this histology of disease, how did they do? If you match for stage and histology, young women still do worse. And that really suggests that there is something going on in young women's breast cancer that makes it more lethal than cancer of older women. And in fact, young women with localized cancer, stage 1 disease, are actually 44% more likely to die of breast cancer than older women are. This is data from a paper that we published in JAMA in 2013, looking at finding that we had noted in the SEER epidemiology database, which was that the incidence of metastatic breast cancer is rising rapidly since the mid-1970s in the United States among younger women diagnosed with breast cancer. And so this is to be distinguished from cancer that metastasizes, that's diagnosed at an earlier stage, and later it goes on to, to get into the liver or the lungs or the brain. This is cancer that has already spread at the time of diagnosis. And the number of young women who are diagnosed with metastatic disease at diagnosis has actually tripled since the 1970s. Far too quick for a genetic change, suggesting it might be a toxic environmental exposure or a modifiable lifestyle risk factor, something like that. But we note the greatest increase in metastatic disease at diagnosis is in the youngest women, and that this increase in incidence in stage 4 disease at diagnosis goes up to about age 49, but is actually not found in older populations diagnosed with breast cancer during this time frame. Unfortunately, the incidence of metastatic breast cancer at diagnosis is accelerating when you look at more recent time intervals. And we've done recent analysis with all data that are evaluable from the SEER database now. And this increase continues at an exponential rate. So again, the reasons for this change are not known. You can't implicate more people having BRCA mutations, et cetera, to cause a change like this in just a 30-year period. But we have to look really closely at what's going on in our environment and what's going on in terms of people's lifestyle, because something must have changed in the United States in the past 30 years. Now, women under 40 are an unscreened population, right? They're currently not recommended to get mammograms. And in fact, breast cancer is relatively rare, and there is possible harm that can be done from doing a lot of breast cancer screening. You find lumps, you have to do surgeries. So it's not a completely risk-free procedure, and it certainly is expensive for the healthcare system to do mammograms. So there's no recommendation and none forthcoming that women under the age of 40 should begin to have screening mammograms younger. But that means that people have to be aware, and young women and their doctors tend to think that breast cancer is rare, and so perhaps not react very quickly to a new breast lump, particularly if the woman's nursing or has some other reason that one could think of to have lumps in their breasts. And so I think what we all need to remember today and going forward, and what we all need to share with our patients and with our friends and know for ourselves, is that if a young woman has a lump in her breast, no one should be reassured just because she's young, and those lumps deserve just as much workup as they would if they occurred in an older woman. So having had breast cancer twice, the risk factors for breast cancer are of significant interest to me. And so I want to go through some of them and talk about how the risk factors for breast cancer in older adults differ from those of young adults. So the risk factors with a little asterisk are risk factors that occur both in young and in older women. And the ones without an asterisk in these forthcoming slides are ones that only are relevant to adolescents and young adults and not older women. So a positive family history confers a relative risk of 3.2. That is a significant increase in the risk of breast cancer if you've had a relative with breast cancer. And that's true, again, whatever age a person is and whatever age their relatives have been. The earlier your relatives were diagnosed with cancer, the higher your personal risk for cancer will go in the calculator algorithms that are widely available these days. Now, there are many constitutional mutations. These are germline mutations that occur in every cell of the body and can be passed through the generations. And these mutations significantly increase the risk of breast cancer among women. And what's done these days is usually a panel of genetic tests to look for germline or constitutional mutations in this and other breast cancer genes. And it's super important that young women have these panels done to understand if there's any identifiable genetic risk. The reason that that's so important is because if the woman is diagnosed with a specific genetic change that has increased her risk for breast cancer, you can then test relatives specifically for that genetic change and find out if her sisters, if her mom, if her cousins are also at risk for early onset breast cancer in that same way, or if they're not. So young women with breast cancer should always be offered genetic counseling and, in my opinion, a genetic testing panel with genes, including the ones listed here. So interestingly, in young but not older women, tall stature and Black race are risk factors for breast cancer. So tall women and Black women are more likely to get breast cancer as adolescents and young adults. There are a bunch of hormonal risk factors for breast cancer that many of us are aware of. So early menarche at older age at first birth impart risk for breast cancer, and that's true in all age groups. Also, ovulatory infertility is a risk for developing breast cancer. Now, for young women, there's an increased risk for several months postpartum. And so one of the hypothesized reasons that breast cancer incidence overall may be increasing in adolescents and young adults is that women are having their kids significantly older than they did in the 70s. And so the breast tissue may be somehow different. Certainly it's older after the woman has gone through a delivery, and perhaps that is a risk factor that, at least it's one thing that's changed in our population, which could be related to the increased incidence of breast cancer that we're seeing in young women in the United States these days. Oral contraceptive use raises breast cancer risk by at least twofold for everyone in the AYA period. And oral contraceptives are certainly widely used. It's the exogenous estrogens that confer this excess risk more so than progestins. It's an especial risk for BRCA1 and 2 carriers. And so young women who have not been diagnosed with breast cancer but do carry the BRCA gene should get careful counseling about what type of birth control is the best for them. And another age-specific risk factor for AYAs is early multiparity. So having a lot of kids very young is a risk factor for breast cancer in the AYA period that does not extend for some reason into older age. And the increased risk for a few months postpartum may potentially be related to that finding. And then there are personal and lifestyle risk factors. So in all age groups, smoking and heavy alcohol intake and prior irradiation to the chest wall are known significant risk factors for breast cancer. More recently, smaller studies have reported that high red meat consumption is a risk factor for getting breast cancer in all ages. And it's interesting because that is consistent with other recent studies that have been done in the AYA population, showing that high red meat consumption is a significant risk factor for colon cancer as well. So I think as a population, we're going to really need to begin to rethink dietary choices. When I first started practicing AYA oncology about 15 years ago, I would hear lectures and think about what's called the Cancer Continuum. So, the first is prevention, and what can you do before you ever are diagnosed with cancer to not get cancer? And then it's what do you do to best treat the person during their cancer diagnosis? And finally, how do you manage late effects and survivorship after the person has hopefully been cured of their cancer? And when I first started in this field, I thought, well, the pre-diagnosis phase, cancer prevention, can't be a really very big factor for young people, can it? Because, of course you shouldn't smoke, and of course you shouldn't tan, because you could get lung cancer and melanomas, but besides that, what can you really do? And I think we all need to look really closely at diet and exercise and what's coming out about dietary patterns and particularly changes in the microbiome, which are closely related to dietary choices. And I think that young adults in the future hopefully will have a much better idea based on research in these areas as to how their dietary choices affect their cancer risk, not just in 60 years, but in just years or decades following the choice to eat red meat or other things. So other personal and lifestyle risk factors for young women. So obesity is a risk factor for breast cancer in postmenopausal women only, but not as a single variable, not for young women. In fact, thin body habitus is a risk factor for getting breast cancer as an AYA, and people with a low BMI, a thin body habitus, have a relatively increased rate of getting the aggressive basal and HER2 subtypes of cancer. However, I think the story is more complicated than that. And again, it's been my opinion that we need to look really closely at the dietary and activity patterns of Americans, because the obesity epidemic has soared since the 1970s, and so has the rate of advanced breast cancer in AYAs, and in fact, the cancer incidence in AYAs, as I also showed you. So if you look at several variables at a time in smaller studies, there is a signal that a sedentary lifestyle in combination with obesity and high caloric intake is in fact predictive of an increased chance of getting breast cancer in the AYA period. Also, people who gain a significant amount of weight after the age of 18 are more likely to get AYA breast cancer. Now, fortunately, there have been some studies, many of them fairly recent studies, showing significant protective factors that can help people not get breast cancer. So we've known for a long time that breastfeeding is a very good way not to get breast cancer. The final stages of breast development are thought to occur with the onset of the first lactation. And in addition to that, the more breastfeeding women do, the more months that they breastfeed, the lower their risk of breast cancer. And this association is strongest in the youngest women. Vigorous exercise in the AYA period in, again, relatively small studies, but several of them do show protection against getting breast cancer as an AYA. More plants in the diet are also shown in smaller studies to potentially be protective against breast cancer. And these tend to be kind of reductionist type of studies. So people are looking at one thing that might protect against breast cancer. And so people have reported cruciferous vegetables protect against breast cancer. Citrus fruits, eating more tomatoes can protect against breast cancer. Substituting, I like this study, substituting legumes for one serving of meat daily. People who do this decrease their risk for AYA breast cancer by almost 20%. So all of these things are suggesting that there's a substantial benefit of a plant-based diet to help people not get breast cancer in the AYA period. I have a daughter, and she hears a lot about this from me. And in fact, after my second breast cancer diagnosis, I figured I need to do everything I personally have a choice about to decrease my breast cancer risk. And so I adopted a plant-based diet at that time. And I really do think that as we go forward in years, that adequate fruit and vegetable intake and less red meat intake, and probably less meat intake altogether, is going to turn out to be protective against multiple types of cancer. So keep an eye on the literature about that. High vitamin D intake has been found to be protective for AYA breast cancer as well. Now, risk factors for advanced disease. So you can think about what are my risks of getting breast cancer, and then what are my risks of getting advanced breast cancer, hard to cure cancer that has spread elsewhere in the body. Unfortunately, obesity is a risk factor for advanced disease in young women, in older women, and in other cancers as well. So it could be that the rate of advanced breast cancer in young women has something to do with the obesity epidemic on that standpoint, except for the confounding factor that it's thin and not obese body habitus that is a risk factor for getting breast cancer. So researchers need to tease that out, and I would be so delighted to see more studies done on this topic. Low socioeconomic status is a risk factor for advanced disease for AYA breast cancer, as well as many other types of cancer. And also Black, Hispanic, and Native Americans get more advanced breast cancer in the AYA period than whites do. And also low vitamin D levels at diagnosis is a risk factor for advanced disease for the cancer spreading. So let's talk now about some special age-specific issues that affect young women with breast cancer, and much of this is generalizable to other types of cancer in the AYA period as well. So breast cancer as a young woman has been shown to be significantly related to decreased quality of life. And it seems to be something that is a bit specific to breast cancer, because compared to age-matched survivors of other types of cancer, also young adults, women with breast cancer report worse cognitive functioning, more fatigue, and more insomnia. So the reasons for that are not yet known. Perhaps it's something about the particular type of chemotherapy that's given. Perhaps there are just psychosocial issues with perhaps losing a breast, or their relationship to sexual functioning and body image that breast cancer patients and survivors cope with compared to people who have types of cancer elsewhere in their body. No one knows, and more research is needed. In addition, young Blacks fare even worse than young whites when they have early onset breast cancer. Studies have shown lower health-related quality of life and physical functioning in Blacks compared to whites, and also that Blacks compared to whites with breast cancer in the young adult group have greater fear of dying and more unmet needs for supportive care. So all of these taken together suggest that AYAs with breast cancer are a population that's really at risk for decreased quality of life, potentially due to psychosocial factors as well as medical factors, and that we as healthcare providers need to proactively address these things and work out what types of programs patients need to thrive as much as they can during and after their cancer diagnosis. Other special issues for young adults. So the average elderly adult with cancer is, well, first of all, the average person diagnosed with cancer is likely to be elderly statistically. And then the average length of time that people live after a cancer diagnosis as of a few years ago was about a decade. So most people are diagnosed when they're old. Most people only have a few years to then live with toxicities of therapy. Kids and teens and young adults, however, if they survive, they should live for many decades, which is wonderful that they have that life, but unfortunately puts them at risk for late toxicities of therapy that may occur decades down the road from when they had the chemo or radiation. One issue that affects women with breast cancer is premature menopause. And so women who become infertile as a result of their chemo, of course, can't have children, and many AYAs have not completed the families that they want to have and may be interested in having more kids. But the closer you are to menopause at the time of breast cancer treatment, the more likely you are to go into menopause. And so that's a significant issue. GnRH analogs like Lupron have been shown in small studies of breast cancers patients to actually increase menstrual cycling following the end of chemotherapy. And again, small numbers, but really encouraging, have been shown to improve fertility significantly after breast cancer treatment. And how these drugs work is they sort of like shut down the hypothalamic pituitary axis and make the ovary, instead of like a normal adult ovary, into a kind of quiescent prepubertal type of ovary, decreased blood supply, et cetera. And so this encourages the chemo sort of not to see the ovary in the same way, and is thought to in that way preserve fertility. So the use of GnRH analogs in women with breast cancer and potentially many other types of cancer as well may help with acute toxicities because they won't have menstrual cycling, so may not have heavy periods if their platelet count is low, and lots of bleeding can help in the short term, but also the hope in the long term is that it may help preserve fertility. So that's something that providers should consider offering and patients should consider asking about. People who go into menopause are at risk for osteoporosis. And so if women go into menopause early because of their breast cancer treatment, they have many, many years to have an increased risk of osteoporosis, and that needs to be monitored closely by their physicians. People who have breast cancer have a long time to get second cancers. And in fact, people who are diagnosed with breast cancer at a young age are quite likely, about a third of them will get breast cancer in the contralateral breast at a later age. And so that leads to many discussions in young breast cancer patients about what type of surgery is the best for that specific individual. Is it a unilateral mastectomy? Is it a bilateral mastectomy? And what type of surveillance will they need to look for cancer in the remaining breast if a unilateral mastectomy is done? So doctors should initiate proactive conversations about the need to preserve fertility because, of course, the first dose of chemotherapy can damage the eggs and the follicles in a way that may not be reversible. And so if women are going to bank their eggs or bank embryos, it should ideally be done prior to the start of therapy. And many patients with breast cancer actually do have a little window of time while their workup is being done and surgery or chemo being planned, and they should act on, and then their doctor should offer the possibility of fertility preservation during that window. Sexual health is a whole topic that's distinct from fertility preservation, and that physicians need to think about as well and ask patients about. So patients can get vaginal dryness, fatigue that prevents sexual desire. It can be an issue between partners or for individuals, and it is something that medical professionals shouldn't assume that patients aren't feeling well enough to have sex. In fact, studies show that most adolescents and young adults are wanting to be asked about their sexual health, and that many of them are sexually active during all of their cancer therapy and beyond. And psychological health is also a main issue that physicians need to ask about, instead of just assuming that patients will say something if they're having a problem. I try to normalize the possibility that psychological support may be helpful during therapy or during survivorship. Just sort of say it at the time of diagnosis, and then check in with the patient throughout their treatment. And if they're seeming to have traumatic stress symptoms or problems with coping, then again, having a psychological health provider, a psychologist in the multidisciplinary team is super helpful, and referring patients sooner than later is often helpful to them. So next, clinical management. Surgery is often a component of treatment of AYA breast cancer. It can be lumpectomy with radiation, or patients can get mastectomy. These have equivalent outcomes. For reasons that no one's quite understanding, there is a much higher rate of local recurrence of breast cancers in adolescent and young adults compared to older women. But interestingly, there is not a negative impact on either disease-free or overall survival that's ever been observed in the decades that difference has been known. And so therefore, lumpectomy and radiation or mastectomy are both fine options for adolescents and young adults with breast cancer. Chemotherapy in young women is usually warranted because of the known higher risk of recurrence in younger patients. Chemotherapy has been shown to impart about a 35% reduction in the recurrence risk and a 27% reduction in the risk for death from breast cancer. And it's particularly effective in the basal subtype, so not hormonally sensitive breast cancers, but in the basal subtype, which doesn't express hormones. Neoadjuvant chemo is often used, and the purpose of this is to give some chemotherapy and see if tumors that are invading the chest wall or too large to be removed can be made into tumors that are operable. And it's often used in borderline lumpectomy candidates, and again, locally advanced disease where the tumor is getting into the muscle to shrink up the tumor and make the surgical resection easier and more complete. It's been noted that young women treated at specialty centers compared to in community oncology groups are more often offered neoadjuvant chemo with the intent of making tumors operable. And that raises the point that, you know, this is an at-risk population. And as we talked about earlier, that young women with breast cancer are at much higher risk for death and tumor progression than older women. And so oncologists who treat multiple types of cancers and primarily older women with breast cancer in the community may not be aware of the nuances of treating young adult breast cancer. It's very physician dependent, very center dependent, but it raises the issue that young women should always consider, and their providers should always consider, a referral to a specialty treatment center that has a strong multidisciplinary team and knowledge of the specific needs of young patients. Endocrine therapy is used for estrogen receptor positive early stage patients, and tamoxifen is usually given, and ovarian suppression is often recommended for young women who are receiving chemotherapy in particular. Reasons to refer to a tertiary center. This is from an article I wrote last year with some medical oncology colleagues. And of course, you know, breast cancer is so common that not every single person is going to be referred to an academic center, and not every single young woman would actually benefit from, you know, possibly traveling a longer distance and having an oncologist who's not near to their home. So for some women, being treated in a community setting is probably fine for the patient and a reasonable decision. But here are situations where patients and their healthcare providers should think about referrals to a tertiary care center. First, if the young woman has metastatic disease at diagnosis, she's at very high risk for death from disease and should have options for the newest and best chemotherapy treatments and possibly clinical trials. Second, if a woman's young, has standard therapy and the cancer recurs, referral to a specialty center for a second opinion or discussion of treatment options is warranted. If she's interested in fertility preservation and the center where she is being treated is not set up to do that very quickly, then, since that's so time sensitive, referral to a place that can get the fertility preservation done very quickly is a good idea. If the patient's interested in a clinical trial, those are more often available at tertiary centers, and as well if the patient has locally advanced cancer. And then this is an algorithm of the special considerations for clinical management in young women. So in terms of laboratory tests and imaging, long story short, there's a lower threshold for doing systemic staging scans to see if there is any evidence of distant disease, because the spread of disease, distant metastatic disease, is more common in young compared to older populations. So we recommend that if a patient has stage 2B breast cancer or anything more advanced, that they have systemic staging. Many young women will be able to say clearly if they're menstruating or not at the time of diagnosis, but if they're sort of on the cusp of menopause, it can be really important in terms of the treatment recommendations to understand if they're menopausal or not. The sort of brightest line in breast cancer treatment is, are they premenopausal or are they postmenopausal? So if there's any question, they should have hormone levels checked at diagnosis. Genetic testing, again, I think should be standard for all young women with breast cancer, and depending on the specific genetic mutation, they should have a very strong consideration of bilateral mastectomy if they have an unusually high risk of getting a cancer in the other breast. And so that decision is every woman's prerogative to make, but having all of the information by getting the genetic testing done promptly, and then having a multidisciplinary discussion before any major surgery so that the woman can talk with a surgeon, have all of the geneticist's recommendations be done before she needs a definitive surgery is the ideal state. Fertility preservation should be offered in the form of a referral to a reproductive endocrinologist if the woman is potentially interested in having more kids. You can do oocyte or embryo cryopreservation these days, both with good effectiveness on the back end if the woman chooses to use that frozen gamete or embryo to implant later. There's a significant out-of-pocket cost to that, and insurance often will not pay, which is an ongoing barrier to getting that done. GnRH agonists like Lupron are a good way to essentially shut down the ovary during chemo with the hope of preserving later fertility. although studies are still preliminary in terms of the benefit, but I would say better developed and more evidence in women with breast cancer compared to women with other cancer diagnoses in the AYA period. So the clinician should consider referrals to physical and occupational therapy, psychology, and nutrition to just keep young women as strong and active as they can be during their treatment, realizing that a young person's fitness goals may be quite different than an older person's, and the physical therapists and the providers should be aware of that, young women may want to get back into running marathons and not just be able to walk up the stairs. So tailoring those therapies for the person's specific needs is ideal. And then one needs excellent contraception during cancer therapy. Copper IUD is best for women with hormonally responsive tumors in particular. Barrier methods are also reasonable, and sterilization of either the patient or the male partner is something that needs to be considered. And that is a conversation that needs to be had fully between the patient and the oncologist, possibly a gynecologist if that's needed prior to the start of any chemotherapy. And then consideration of clinical trials is a really good idea for any patient that's at risk for adverse outcomes from breast cancer, and young women with breast cancer are certainly in that group. So finally, I will review the checklist developed by Julie Graylow and Rachel Young that goes over many of these factors we've discussed today. This is very nice. It's from the Journal of Oncology Practice, published last year. It's in PDF form and is a nice, easy way to think about these issues, whether you're a healthcare provider or a patient. And so the idea of checklists has been promoted extensively in medicine in the past decade or so. And the idea is that things are getting so complicated. Specialists are having more and more knowledge that is just intrinsic to their field. And the data comes out rapidly, it changes rapidly. And so checklists sort of help healthcare providers, particularly who are the ones that don't keep all this information in their heads, help sort of share the knowledge and experience and make it very cut and dry and quantifiable, and help with clinical management in that way. So in terms of the diagnostic workup, young women should have a low threshold for distant staging to look for metastatic disease. Some women who have breast cancer in one breast and are at risk for, say, a subsequent breast cancer, either in their remaining breast tissue in that breast or in the opposite breast, may be recommended to have breast MRIs in addition to mammograms. So that's an important thing to offer people who are eligible for that. I think all young patients should be referred for genetic counseling and testing. And if positive results are found in the patient with cancer, then their family members can be rapidly screened for the presence of that same mutation, which could affect their own breast cancer risk and screening, and might have real implications for the rest of the family. All young breast cancer patients should think about fertility. If they haven't had all the kids they want, they should be referred to an onco fertility clinic for discussion of fertility preservation options, which they can then decide to pursue or not. They should be offered a GnRH analog during chemotherapy to preserve their ovarian function. Again, it's optional, patient by patient, if they're interested in that. The surgical options for breast surgery should take into account that genetic testing results might affect a person's decision. So again, a multidisciplinary discussion is best, and young compared to older women are more likely to choose a prophylactic contralateral mastectomy because of the significant risk of recurrence later. And it is a person by person choice, but I think as healthcare providers, there's a lot we can do to support that decision making. When considering recommendations for systemic therapy for chemotherapy and radiation, offer clinical trials when possible. providers should think about the patient's young age and menopausal status on how much chemotherapy will benefit them. Long story short, it tends to be more beneficial for young compared to older patients. Consider suppressing ovarian function and consider the use of adjuvant bisphosphonates. These are often used to prevent distant recurrence in postmenopausal women, but the data is not as strong in younger women, and those recommendations change over time. Assess patients routinely for anxiety, depression, social isolation, fear of recurrence, and recognize that the breast cancer diagnosis can affect not only the individual, but everyone she interacts with, her partner, her kids, parents, friends, etc. And there are a lot of peer support resources, particularly for young breast cancer patients. And so having a list of those and referring young women for national or making sure that young women have access to national resources for breast cancer information, but also for peer-to-peer support. It's important to recognize in the breast cancer community that there are some really good peer-to-peer support options that are for all different types of cancers and not just breast cancer. And so women with breast cancer at a young age should look more broadly than just the breast cancer literature. When you ask people who have used some of these resources and nonprofit support groups, they tend to have a very positive reaction to them and feel that it's helped them with coping a lot. So I would encourage people to reach out and try some of those at whatever time they feel is the best for them. Cancer can have major impacts on career and occupation, particularly in the AYH group. Cancer diagnosis can really derail somebody's career progression and often cause financial toxicity and even bankruptcy. So people tend to be at lower stages of their career and may lose their job during breast cancer diagnosis and treatment. And again, the financial impact of that can be tremendous. And so again, healthcare providers should be aware that financial toxicity might be something that patients are living with, worrying about, and not mentioning to the healthcare providers. And there may be resources available within the hospital or in terms of national grants for AYA cancer survivors, et cetera. Lack of financial resources may be a reason that patients don't come in for appointments or scans. And so the healthcare team should sort of look into apparent non-adherence of patients and see if that might have a financial toxicity component, because that may be something that that could be addressed and made better for patients. Finally, screening for second primary cancers is going to be needed in survivors of young adult breast cancer. So people should discuss with their healthcare provider the need for breast MRI for high-risk screening after the breast cancer treatment is finished, and then thinking about the best ways to screen dense breasts, because breasts are more likely to be dense in younger compared to older women, and that makes mammography potentially more difficult. And there are new modalities being developed to image dense breasts that young women should think about. And then in addition, genetic screening and referrals to other services should always be considered and offered to young women. And then people need long-term monitoring for side effects. Women may become menopausal during their treatment, and estrogen depletion and premature menopause can cause vasomotor symptoms and hot flashes, insomnia, and vaginal dryness. And those are things that women may not immediately relate to their treatment. So they're things that providers should ask about, and they're things that people should mention to their physicians if they begin to occur during or after AYA breast cancer treatment. And finally, then providing the appropriate referrals for fertility and contraception, sexuality counseling, pain management are super important. Keeping careful track as cancer survivors age in bone health and cardiac health and lifestyle are all important. One interesting factor is cardiac health. You know, in pediatric oncology, we are often doing echocardiograms to make sure that people aren't developing cardiomyopathy, particularly after having anthracyclines like doxorubicin. And I think that that is less often an element of care in breast cancer survivorship and in adult cancers in general. However, it should be noted that pregnancy increases the circulating blood volume by 40%. And therefore, pregnancy is a risk time when an underlying cardiomyopathy, heart damage from a previous chemotherapy, can rear its head. And so, again, healthcare providers and patients should be thinking about cardiac health in women who are cancer survivors and then become pregnant. And I think as an oncologist that there's more we can do in the medical profession to proactively counsel patients about healthy lifestyles. So nutrition, appropriate exercise, weight management. Obesity is a risk factor for, again, breast cancer in older women, but women who are obese actually have inferior survival from breast cancer compared to women who are of a normal weight. And weight loss decreases that risk in breast cancer survivors. So it's very interesting and to know that, and also very important to let patients know that, because breast cancer survivors, therefore, who are overweight, have something they can do to potentially improve their own chances of living through the cancer. And then palliative care for patients who have disease progression is incredibly important. Support for the patient and for their families. And the issues relating to mortality at a young age can be different from that at an older age. And so obviously important to carefully think through the problems of the patients in that group and support their needs as well as possible. And with that, I will thank you for your attention and for attending today, and happy to answer any questions.
Dr. Johnson, for an extremely informative presentation. We are running out of time, but we look like we have time for at least one question. We did have a question submitted about if you have any statistics on Asian American females in terms of their risk of the AYA group.
So the Asian, I want to say off the top of my head that they are not at as high risk for AYA breast cancer as Blacks and Native Americans, and the risk is closer to that of Caucasians. And I can't remember off the top of my head if it's just a little bit more or a little bit less than Caucasians. It may even be a little bit lower than Caucasians, but don't quote me on it. But it's not dramatically high like it is in those other two ethnic groups.
Okay. If the risk of breast cancer in the AYA group is steadily rising, is there anything being done to potentially recommend screening at a much younger age?
There's not actually, and that's because
offspring of women who have already had cancer, and these are the offspring where their chances may also be increased.
So the question then is, should all women be screened at a younger age, and also should high risk young women be screened at a younger age? Is that right?
Yeah.
Okay. So the answer to the first one is no. All women shouldn't be screened younger because of the fact that there is morbidity potentially. If you have lots of scans that cost lots of money, that lots of lumps are found, and then biopsies done, which can lead to, later problems with breastfeeding or infection. And so the risk benefit has been looked at pretty carefully. And even though the risk is increasing in young women, it's not felt to be high enough to screen everybody. However, the story for young women is much different. And so certainly the young adult children of people who have had breast cancer should be seen at a high-risk breast clinic. Probably virtual visits are easier than ever to obtain for that type of a service, even compared to before the pandemic, because young women should sometimes begin mammograms and screening MRIs very early if they have a strong family history of breast cancer. And also, if genetic risk can be identified in those people based on the genetic profile of their relatives with breast cancer, that actually is really important as well. So yeah, young relatives should definitely get into a high-risk clinic probably as soon as they turn 18.
Oh, okay. Oh, that's interesting.
Yeah.
Well, unfortunately, we've run out of time, but thank you, Dr. Johnson, for an informative program, and thanks to all of you for participating and submitting questions. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser at the end of the webinar, and the link will also be included in the email. All surveys are anonymous. And thank you once again, Dr. Johnson, for all the information. And this concludes our webinar. Thanks, everyone.
Thank you.